Oh, great. Mr. Johnson, your doctor's here. Let me talk to him just 1
I'll
second.
be right with you, okay, Mr. Johnson? Hi, Kyle. What's
Hi,
up?
Dr. Chu. So this is Mr. Johnson. He was visiting his wife. He's a 77-year-old gentleman visiting his wife here in the hospital, and he noticed his heart rate was racing. So the nurse took his pulse, and it was elevated, brought him down to the ER. I triaged him, and he has a heart rate of 160, so I brought him straight back. I just got him on monitors. His heart rate is 160.
160?
Yeah, heart rate, blood pressure is 120 over 80, and his SAT is 97 right now. What else would you like me to do?
Well, let me quick take a look at his rhythm here. Mr. Johnson, I'll be right with you, okay? Wow, that is quite fast. Geez, I'm really not sure what rhythm that is. He's tachycardic, though. But it seems like he's hemodynamically stable. Mr. Johnson, we're just going to get a few more things for you, and I'll be right with you, okay?
All right,
Kyle, I
thank you,
think we
doctor.
need to get a few extra people here. I'd like to get an IV started. We need to get a 12 EDKG. I'd like to get some pads on him. And let's get someone just to bring the crash cart in, just in case.
Okay, so I'm going to go get some more help, and we'll get that going.
Okay, great. Mr. Johnson, tell me a little bit more about your medical history. Have you ever had any heart problems?
No, not really.
Ever have any chest pain or ever had a heart attack?
No, I never have. My doctor just told me that I had some beginning diabetes, but I don't have any treatment whatsoever.
I see. How are you feeling right now? Are you lightheaded or dizzy?
A little bit lightheaded. I feel that my heart is racing.
You feel like does it feel like your heart's going to jump out of your chest, kind of?
Yeah, a little bit.
How long has it been like this?
About 10 minutes. It just started.
Okay. Dude, what were you doing when it happened?
I was just visiting my wife. We were just calmly talking.
We're going to give you a little oxygen
Okay.
just to help you with your breathing, okay? Well, Mr. Johnson, what we're going to do is we're going to start an IV so we can give you some medicines. I want to do an EKG just to see what your heart is doing. We're going to give you some oxygen, and we're just going to do some more tests so we can figure out what's going on, okay?
Okay, thank you, doctor.
All right.
Dr. Chu, do you want me to actually hook up the defibrillator?
Yeah, I'd get everything. I'd get the pads on him just in case.
Mr. Johnson, I'm going to put some sticky pads on you here, okay?
Okay, perfect.
Dr. Chu, the IV is placed.
Okay, great. Well, I tell you, I just can't get this morphology, Kyle. I think we might have to give him some adenosine here just to see if we can get his heart rate down and see what the underlying rhythm is.
Okay.
Can you get some for me?
Let me draw that up.
Okay. Hi, welcome back. I'm Dr. Larry Chu,
And I'm Dr. Kyle Harrison.
and we're the co-directors of this course that you're taking about advanced cardiac life support and crisis management. So let's talk a little bit about the scenario that we just saw. This was a 77-year-old gentleman, Mr. Frank Johnson, who came into the hospital to see his wife. And while he was in the hospital, he had an episode of feeling that his heartbeat was beating very fast. He was then taken to the emergency department. He was brought into one of the beds, and then when the scene opens, you see the attending coming to evaluate the patient and getting a report from the emergency room nurse. Kyle, let's talk a little bit about this initial management that they saw. What were some of the things that they did right in terms of management of a tachycardia?
Okay. So if you notice, the first thing they did is they put him on the monitor, because you need to decide, when you just do a pulse check and you have a rapid pulse, you want to decide what rhythm you're dealing with. So they put him on the monitor. They were able to identify that it was a narrow complex tachycardia. The heart rate was 160. So next thing they did is they checked the blood pressure, and the blood pressure was good. It was like 120 over 80. And the patient was having no complaints except for feeling like the chest was racing inside the patient's chest. So they were able to very quickly decide that this was a narrow complex, stable tachycardia, which is an important determination to make, because you have a little more time to proceed at that point. Once that assessment was made, then they decided to start treatment while they also started to gather more information, which is a key point, because you've got to be working ahead of the curve here, because the patient may become unstable at any moment. This is an elderly patient. Heart rate is fast, even though they're stable at this moment, they may decompensate. So they needed to rapidly establish IV access, wanted to get a 12-lead EKG to confirm the diagnosis, wanted to place the patient on oxygen. And they thought, maybe this patient may get worse. Maybe I should go ahead and bring the crash cart in just in case, anticipating that the patient may become more unstable.
Well, let's talk a little bit more about treatment. I know this is also crisis management. We'll talk a little bit about the principles of crisis management that were used in this scenario in just a bit. But in terms of the initial treatment, tachycardia is something that we as clinicians do see fairly often, but probably not to a degree such as Mr. Johnson, where he was tachycardic in the 160s. Talk to us a little bit about beta blockers. Could this patient have just been treated with a beta blocker?
So that's a good point. First thing you need to decide why this patient is tachycardic. And is it a sinus tachycardia or is it a dysrhythmic tachycardia? And why that is important is a sinus tachycardia is a reflexive response to an underlying physiologic stress, either hypotension, fever, sepsis, pain, you name it. And the reason why that's important to note is that you may not want to treat the heart rate without understanding and discovering the cause. You may want to treat the cause first. Now, one thing that tipped you off this may have been a dysrhythmia was that it was greater than 150. Most people will not generate a sinus rhythm above 150 beats per minute. So that was your first tip that this wasn't sinus. But you don't just go in reflexively start slowing people down if they're in sinus tach without fully understanding what the mechanism is, because that may be the only reason they have adequate blood pressure is because they're driving their heart rate so quickly. So you want to drill down on the underlying cause before you treat a tachycardia. But if it's a dysrhythmic tachycardia, then controlling the rate is a choice. You can, in a stable SVT or AFib, a flutter, unknown yet what this is, you can give a beta blocker. You can give a calcium channel blocker, but that assumes that the patient is stable. And usually their heart rate's not going to be 160 in those circumstances. Those are going to be the patients that are in atrial fibrillation, their heart rate's 120, and you want to slow them down. That's a little different. This is a really fast dysrhythmia, so I think you really got to be cautious about giving a beta blocker at this moment to this patient.
So it sounds like we needed to institute some type of treatment here, oxygen, for instance, but at the same time performing some additional diagnostic examination on this patient, given that we had some time, because he was, at the time that we saw him, hemodynamically stable.
Right.
Let's talk a little bit about the crisis management issues that we saw used during this first part of the scenario. So I think probably one of the big ones you've already mentioned, which was anticipate and plan. Some people might say you called for the code cart too early. What do you think about that?
Well, I mean, calling the code cart, bringing it in, they didn't call a code. I think that there's a difference. Having a code cart, which has the defibrillator, which is also an ability to cardiovert someone, is excellent to have at the bedside. So I think that was an appropriate thing. You can get the pads on. You can have additional drugs like adenosine, which is actually a drug that they called for later. That's in the crash cart. You have amiodarone in the crash cart. So you've got a lot of resources that are bundled in the crash cart. So I think that was actually a good use of a resource by bringing that in.
Is it ever inappropriate to call for a code cart?
I think, honestly, if you feel the patient is unstable or potentially may become unstable, then it is appropriate to have that. If you just want to bring it in the room and not set it up, that's one kind of a baby step. But assuming that you have adequate resources, you're not taking away from another patient, then I think that is an.
And I think one of the things, the lessons that we'd like to teach in this series is that it's always important to call for help while it can make a difference. And calling it early is usually when it can make a difference.
Absolutely.
So Kyle, why don't you talk about some of the other crisis management techniques that we saw in this scenario? All
right, so another important one that you saw was this patient needed to have several things done in a very expeditious manner. Patient needed EKG, needed an IV, needed oxygen, and the crash cart needed to be brought to the bedside. Those are way too many things for one person to do in a very quick manner. So he asked for more help, so more additional nurses came, and he distributed the workload to all those additional providers to become much more effective and efficient in delivering those treatment priorities quickly, which I thought was good.
Great. Well, I'm dying to see what happens next. At this point in the scenario, we have a patient who has stable tachycardia, but I think there's more things that need to happen. So why don't we take a look, and then we'll come back to you after the break.
Okay.
Okay, I'm just checking his cognitive aid to make sure I haven't forgotten anything.
Dr. Chu, I have the 6 milligrams of adenosine ready.
Oh, great, Kyle. Can you go ahead and give the 6 milligrams IV push, follow that with normal saline? And
Okay.
I'll have a look on the monitor while you do that,
Okay.
just to see what that rhythm converts to.
I'm pushing 6 milligrams of adenosine IV push, and I'm pushing saline flush in.
Okay,
So Johnson, I'm giving you a medication here.
here we go. I'm seeing something. It looks like AFib. Kyle, I want you to go ahead and get 150 milligrams of amiodarone ready. We'll give that as an infusion over 10 minutes.
Okay.
Anna,
Yes.
I'm concerned just that if Mr. Johnson becomes unstable, we may need to do a cardioversion. Can you let cardiology know and also give anesthesia a heads up? We might need to have cardioversion ready.
Okay.
Okay. A lot of stuff happening here. Now, the scene opens up and we're giving adenosine. Talk to us a little bit about why we would give adenosine in this scenario. Why is adenosine an important diagnostic and or therapeutic tool for this patient?
So adenosine, what it does is it causes a very high degree AV block. And the thought is, if this is a reentrant SVT, that high degree AV block will stop the reentrant pathway and allow normal conduction to resume. So that's how it can actually be therapeutic, in that it actually converts the patient from an SVT back into sinus.
Supraventricular tachycardia.
Right.
Okay.
Right. So this was a narrow, complex, fast rhythm. Now, in this case, they gave it, and it slowed down, and it actually was. You were able to identify that this was actually an atrial fibrillation patient. Now you can say, well, shouldn't you have known that before because the patient was irregular? Well, it can be hard to assess regularity when the patient's going 160 beats per minute, because the irregularity is coming from the intermittent conduction through the AV node, depending on the rapid ventricular response of the patient. So if they're going really fast, you may not see the irregularity, whereas you slow them down, then you'll see the more irregular atrial fibrillation waves. So they gave it. It turned out to be diagnostic, not therapeutic. So they didn't repeat it. The normal dose is 6 milligrams. Followed by a rapid push, because it's rapidly metabolized by the red cells. So you have to give it very quickly and flush it in. And then if this were not atrial fibrillation, this were an SVT, and they flip back into it, you could repeat the dose, double the dose to 12 milligrams. But once you saw this as atrial fibrillation, adenosine's not going to convert that. It was now a diagnostic tool, and they moved on to the next agent, which was amiodarone. And this is one of the antiarrhythmics that you can select. It's both effective, both ventricular and atrial tachydysrhythmias. Important to note that it's 150 milligrams over 10 minutes. That's the load. Don't push it.
What happens if they push it?
Hypotension can be profound hypotension, especially in a patient that has a rapid heart rate to begin with.
Okay.
So don't want to do that.
Let's talk a little bit about the crisis management techniques. I think when we first opened up on the scene, you saw the attending physician using a cognitive aid. In this case, making sure, cross-checking, making sure that everything that should be done for management was being appropriately done, or at least considered. And I think one of the other things that we want to teach and come out of this series of lectures is the concept of using cognitive aids. I think they can be helpful. They can help you make sure that you keep on task and that you are not forgetting to do things, which I think in a crisis situation can be easy to do. Let's talk a little bit.
Let me just follow up on that.
Yes.
He even got everything correct. This was a cross-check, and that's fine. We encourage that. Just because you're doing it right doesn't mean you shouldn't cross-check it. There'll be times that you will discover something new, but use it no matter what. Even if you know this in and out, there are going to be days that you're just not hitting 100%, and that cognitive aid is going to help you. Remember, it's more important to help the patient. So follow through and use it on any unstable patient.
So some other techniques of crisis management that were used in this scenario, closed loop communication that you may have noticed throughout the scenario. When I request 6 milligrams of adenosine and Kyle's giving it, he is closing the loop of communication and telling me that he's giving it. And of course, the other big point here was anticipating and planning. The fact that we have this patient in atrial fibrillation who may become hemodynamically unstable. We anticipated for that. We planned for it by asking Anna to notify cardiology and anesthesia to come and do a consult so that we would be able to cardiovert him should he become hemodynamically unstable.
Yeah, I think that's key. He's now refractory to your first-line therapy. You're trying additional therapy, but it's getting more prolonged in this rapid rate. His probability of becoming unstable is getting higher, and you're likely going to need to admit this patient. So go ahead and activating those consults, is an important step. So let's see what they do next.
Great, let's see what happens.
Okay, Dr. Chu, I have 150 milligrams of amiodarone that you want me to give over 10 minutes. Is that correct?
Yeah, why don't you go ahead and piggyback that in and we'll get that started.
Okay.
So Mr. Johnson, we're just going to give you some medicine here to help your heart, okay?
Oh, Doc, I'm not. This is getting worse. I'm not feeling good. I'm more dizzy, and I'm
You're
starting
feeling
to have
dizzy?
some chest pain.
Kyle, let's cycle a stat blood pressure.
Okay.
We're just going to check your blood pressure here and see how you're doing, okay, Mr.
Cycling
Johnson?
Can we put his head down a little?
Yeah, let's put
Lower your head down a little, Mr. Johnson.
Mr. Johnson?
Mr. Johnson.
Mr. Johnson? Okay, he's unconscious. Anna, get ready to help him with mask ventilation. Kyle, I think we have to do a sync cardioversion.
Okay.
I'm feeling for a pulse here while the blood pressure is cycling.
Okay, I've got pads on. I'm just going to turn it on the defibrillator.
Go ahead and get ready for sync cardioversion.
Okay.
200 joules.
200 joules. Okay, I'm increasing this to 200 joules. I'm turning on the sync. And I'm going to charge.
Let me know when you're ready.
Okay. Looks like he's still in the rhythm. 78 over 42 is his blood pressure.
Okay, Anna, clear, everyone clear?
Clear.
Get ready for sync cardioversion.
Charge.
Go ahead,
And
deliver the charge.
energy delivered.
Let's take a look here.
Looks like he's changed his rhythm.
We got him back.
You may check the blood pressure.
Yes, let's cycle another blood pressure.
Okay, cycling the blood pressure.
Mr. Johnson,
Yeah.
can you hear me?
Yeah. What's going on?
You just passed out there for a little bit, but we got your back, okay?
Oh, thanks, Doc. What happened?
Well, your heart just started having an irregular rhythm, so we had to shock it, but now it's back. I think what this means, though, is you're going to have to stay in the hospital for a little bit. You want to have the cardiologist see you and get everything worked out, okay?
Okay. Thank you, Doc.
Great. So it looks like we saved the patient
That's
eventually.
good. Yeah, exactly.
We had a bunch of other things happening before that happened. So let's rewind a little bit. We gave the patient the amiodarone.
Started to hang it. Didn't even really get much of
So
it.
you
going.
didn't really get, because we did mention amiodarone can cause hypotension.
Right.
And what we noticed is as soon as we just started hanging the amiodarone, Mr. Johnson said that he was feeling lightheaded and dizzy, that he was having some chest pain. And then he became unconscious. Now, when that happened, what's the first thing that we should do?
So we've switched from an unstable tachycardia, we switched from a stable tachycardia to an unstable tachycardia. So the treatment now is a synced cardioversion.
If the patient didn't lose consciousness, would it still have been considered an unstable?
That's a good point. So the fact that this patient is now hypotensive, 75 over 40, and they're complaining of chest pain and complaining of dizziness, we've got multiple organs that are affected. So he's having hyperperfusion of his heart, hyperperfusion of his brain. He's got documented hyperperfusion with low blood pressure. This patient's unstable even without loss of consciousness. But with the loss of consciousness, it's even more pressing. This is time to go. It's time to cardiovert him. There's no time for sedation. There's no time for waiting for a cardiologist, no time to wait for anesthesia. You just got to do it. People are uncomfortable doing this, but it's the right thing to do because if you delay it any further, the patient's now going to become pulseless. And then you're going to spin off into the PA algorithm. you've got a chance to pull them out right now by doing the sync cardioversion.
So he still had a pulse. So the plan is then to do a synced cardioversion,
Right.
which we proceeded to do very rapidly.
Right.
We
200 joules.
we distributed the workload and had Anna go and maintain the airway just to make sure that he didn't become apneic,
Right.
to assist his ventilation as necessary because he was unconscious.
And that was key because I don't think people appreciate hypotension. If you're not perfusing the brainstem, patients may go apneic. So the team leader thought about that and realized this guy, before I can get him back, he may actually go apneic, and I want to have someone there ready to support his ventilation if he does. So
Now,
that
while
was
we're
key.
talking about ventilation and the airway, should we now pause synced cardioversion in order to secure the airway within a tracheal tube?
Absolutely not. This patient needs prompt, immediate cardioversion. That's what's going to get him back. You don't want to delay it any further. No more meds. This is PG&E, electricity to the patient. You got to do the cardioversion.
Let's talk about the cardioversion process. So for synced cardioversion, what's required? Let's talk a little bit about the cardioversion device. Each hospital may be different, but in general, there's a minimum required setup in order to perform synchronized cardioversion. Talk to us a little bit about that.
So you're going to use the same modality you would for a defibrillation. It's the same monitor, and you're going to turn it to defibrillation. We say cardioversion and defibrillation are the same thing. It's just cardioversion is a controlled thing in a synced mode. Defibrillation is unsynced. But the apparatus is the same. You put the pads on, you turn it on.
Let's talk about the quick combo pads for a second. Are they sufficient in them of themselves to place on the patient? Do you also need to put on the EKG leads from the machine?
That's a good point. You do not need the ECG leads if you have a second monitor, if you're doing a cardioversion. Now, if you're doing pacemaking, using the pacer, you do need both features. And we went over that in the bradycardia module. But for a cardioversion, you just need the pads. You can't use the paddles. A lot of the machines won't allow you to do a synced cardioversion with the paddles. So you do need the pads, but you don't need to put the ECG on. You can, but if it's going to delay the prompt cardioversion, then don't. You put them on, you turn on the defibrillator cardioverter, you set the joules. So this was 200 joules because this was a narrow complex irregular rhythm. So the selected energy to start with is 200 joules. You hit the sync button. And if you notice, there's a little triangle that goes on top of the R wave, and that says that it is synced. And it's important that you have that triangle on the R wave, because if you don't, the patient may receive energy in the T wave, and which would result in the classic R and T phenomenon, which could put the patient in ventricular fibrillation. If you do that, all you would need to do is simply defibrillate them right away, just unsynced cardioversion or a defibrillation. But that's only if you put them into VFib, which is pretty rare, as long as you have the sync button on. So synced, shocked, and the patient was returned back to sinus rhythm, and the blood pressure improved.
I have a question for you. What if he didn't convert after that first sync cardioversion? Now what are you going to do?
So you just go again and resync it. It's an important thing because after each energy, most defibrillators unsync themselves. The thought is that if you then put someone into ventricular fibrillation with your cardioversion, then you want it ready to go so they take it out of sync mode. I've seen it happen more regularly that sometimes people don't realize that and they almost cause a problem by not resyncing it. So you would simply resync and charge again. If the patient continued to stay in this rapid rhythm, then you're going to give IV fluids. At that point, I would start hanging the amiodarone to see if you can get some effect. If they become pulseless, then you're going to have to switch to the PEA algorithm or the VT. And once again, it's an assessment on if it's shockable or not. Your assessment was that this was a shockable rhythm, even though it's narrow complex. So you may have to just continue to do compressions and cardioversion, which would be unsynced once they're pulseless, and then give epi as you move down the road. But that's only if they deteriorate further. But the key is you may have to do it again, just resync it, and consider increasing the energy.
Great. Well, I think we've certainly showed you a lot in this lesson, a lot for you to think about. And in terms of a wrap-up, I think a good follow-up for you would be to view our lesson on using the defibrillator. And we'll see you next time.
Okay.